Prevalence of drug-resistant tuberculosis among children in China from 2000 to 2010 by Lisa Romano, Kan Doon, Arlene Aguilar, Mai Yang, Suzette Aranda, and Jessica Carbone, California State University, Long Beach. Before we further discuss this topic, let's go over some important concepts. Drug-resistant tuberculosis, or DRTB, is a type of tuberculosis that has been found to be resistant to at least one type of treatment. Rifampicin-resistant tuberculosis, or RR, is a type of tuberculosis that is resistant to this particular medication. Multi-drug resistant tuberculosis, on the other hand, is a type of tuberculosis that is resistant to at least two of the most common treatments. Also, extensively drug-resistant tuberculosis, or XDR, is the one that is found to be resistant to at least four of the core treatments. Incidence. Cases of drug-resistant tuberculosis have been reported all over the world. However, certain countries such as China are particularly more affected by this type of tuberculosis. As shown in this map by the World Health Organization, out of all new reported cases of tuberculosis in China, 12 to 17% are drug-resistant tuberculosis. This is significantly higher compared to other countries such as the United States, where the incidence of drug-resistant tuberculosis is 0 to 2.9%. Morbidity. A study in 2001 showed that China has carried out surveys of anti-tuberculosis drug resistance in 10 of its 31 provinces. However, the World Health Organization reported that all provinces in China had levels of multi-drug resistant tuberculosis above the global median, and some had been classified as global hotspots of multi-drug resistant tuberculosis. Furthermore, another study showed that almost 25% of the tuberculosis cases in China were children, and almost 25% of such cases were drug-resistant tuberculosis. Mortality. Unfortunately, very few studies have reported on the outcomes of drug-resistant tuberculosis among children in China. One of such studies showed a mortality rate of about 10% in children with multi-drug resistant cases. It also concluded no confirmed deaths of children due to extensively drug-resistant tuberculosis. Economic impact. Reported attempts by the Chinese government to treat its affected population included making fees for treatment more affordable, as well as providing free tuberculosis drugs and x-rays for new patients. Unfortunately, this led to a multi-million-dollar debt in loans and subsidies. A study showed that low-income patients in China pay a total of $149 to $724 for medical costs and treatment for drug-resistant tuberculosis.
Hi, my name is Suzette, and I will be going over the agent of disease and clinical symptoms. The agent of disease of tuberculosis is a bacterium called Mycobacterium tuberculosis. This bacterium will most often attack the lungs, but they can also harm other parts of the body. Mycobacterium tuberculosis is transmitted through the air from one person to another. It's when a person infected with tuberculosis in the lungs or throat coughs, speaks, or sings. When a person is in close proximity to the person with the tuberculosis disease and they breathe in these bacteria, they will also then become infected. When that person breathes in the tuberculosis bacteria, that bacteria will inhibit in the lungs and will start to grow. From there, it will travel once it is settled in the lungs. The bacteria will travel through the blood to the kidney, spine, and brain. The tuberculosis bacteria that is found in the lungs or throat is infectious, but the tuberculosis found in the kidney, spine, or brain are not typically infectious. Mycobacterium cannot be spread by shaking a person's hand, sharing food or drink, or kissing. Drug resistance happens because microorganisms, which include bacteria, fungi, viruses, and parasites, change when they are exposed to antimicrobial drugs. These antimicrobial drugs include antibiotics, antifungals, antivirals, antimalarial, and anthelmintics. When the microorganisms come in contact with the drug, they develop resistance to the drug. This becomes an issue because without the drug, people cannot treat the individual with the infection or disease. Instead, it allows for the spread of it. Clinical symptoms. Some of the clinical symptoms of tuberculosis that are most commonly found in the TB bacteria: growing in the lungs, or having a horrible cough that can last for up to 3 weeks or longer, chest pain, coughing up blood, or sputum. Sputum is mucus that is found deep inside the lungs. Other symptoms of tuberculosis disease include an individual feeling weak, tired, having chills, fever, or sweating at night. It also includes the individual having a loss of appetite and experiencing weight loss. In the discovery that an individual is drug resistant to tuberculosis treatment, primary prevention should be implemented in schools at an early age. When children get the vaccine for tuberculosis, they are creating herd immunity among the school and protecting those that have not been vaccinated. Teaching children to cover their mouths when they cough can protect those that have not yet been vaccinated. In this graph, the color blue represents the drug-resistant cases from 2006 to 2015, and it shows that as the years went by, more cases of drug-resistant TB was found in children.
Hi, my name is Arlene, and I will be going over the mechanisms to control drug-resistant tuberculosis. To begin, I will be going over primary, secondary, and tertiary prevention. To begin, the primary prevention is focused to be centered to prevent the development of the disease. An example of this is laboratory drug-resistant testing and surveys. Secondary prevention focuses on reducing the progression of the disease and detecting the disease before it gets worse, doing that early. An example of this is screenings. So the smear, microscopy, and culture screenings are needed. For culture and drugs accessibility testing, this would avoid the indiscriminate use of drugs and the further spread of resistant strains. In addition to strains, it can make the cause of the epidemic more difficult to determine. It does make it harder to standardize a retreatment regimen for the epidemic first-line drugs. Lastly, for tertiary prevention, it focuses on improving your quality of life and reducing the symptoms of the disease. Examples of this are tuberculosis control programs and control institutions, as well as INH therapy. Therapy with a medical professional is needed. With INH, it has been found to be the best of the essential anti-tuberculosis drugs by preventing the resistance in companion drugs because of its high bactericidal activity and its large therapeutic margin. Thank you.
Hello, my name is Lizette, and I will be going over the host characteristics of drug-resistant tuberculosis in China. So first I want to explain what a risk factor is, since I'll be going over the host risk factors. A risk factor is an exposure associated with the disease, and it is not the same thing as a causality, which is when you're trying to determine the cause of a disease. So oftentimes, if you have a risk factor, people might think that that's the reason that you got the disease, but it might not necessarily be because of that risk factor. So some of the host risk factors that increase vulnerability to drug-resistant tuberculosis included being male, a migrant, 15 to 34 years old, single, and having had previous exposure to primary or drug-resistant tuberculosis, and having had retreatment of tuberculosis. Another variable that increased vulnerability to acquiring drug-resistant tuberculosis was environment. So some of the environmental variables were living in urban areas, migration status, and living in northwest and central China. Migrants may have a higher prevalence rate because of the incidence rates from the place of migration. So where they're coming from, there might already be higher tuberculosis rates, and the type of care available outside of China, it might not be as good. So the north, the west, and central China, some of the reasons that those might have higher prevalence rates are because of the cold climate, and oftentimes in cold climate, people are indoors, they may have poor ventilation, and a weakened immune system. Another environmental variable that played a role in the prevalence of drug-resistant TB was socioeconomic status, or SES. So some of the SES factors had to do with occupation, such as being a farmer, unemployed, or retired, and other SES factors included being uninsured and having low education levels. Farmers might not have received proper quality care in treating primary TB, and that's a risk factor for drug-resistant TB, or their access to care may have been limited. Low education levels may relate to unemployment, and being unemployed or retired may often mean being uninsured. This table for the risk factors for MDR-TB, which is a form of drug-resistant tuberculosis, pretty much just highlights the things I've been talking about already for risk factors. So the highest percentages of patients with MDR-TB were males, 15 to 34-year-olds, and farmers. Surprisingly, close contact with a TB patient was not a risk factor.
As for the variation trends in the drug-resistant tuberculosis based on the data, which range from 2006 to 2015, explains that there has been an increased rate of 14.7% to 27.5 in the children with drug-resistant tuberculosis. The public health and hospital system suffers due to inadequate treatments. Another would be even if there is economic growth in China, the tuberculosis threatens any gains made if the epidemic persists. As you can see on the graph on the right, China is the second highest in new tuberculosis cases. As for the limitations, the transmission occurs within large residential complex, which can host a lot of variable strains, which makes it really difficult to standardize the retreatment of vaccines. And another limitation will be the restrictions to the general results and economic disparities depending on the area of China. Gaps in knowledge. More further research is needed, which includes regular contact investigations. Another would be shedding light on tuberculosis control programs, which will further influence global tuberculosis control. Another thing is the importance to public health to understand about the trends and to acknowledge more information about drug-resistant tuberculosis since it is tough to maintain control. Although it is happening in China, it can also affect any country. With more research in more areas will help us prepare for the future and integrate prevention methods to stop drug-resistant tuberculosis.
Areas for further epidemiological research should include the different transmissibility and virulence among different TB strands. For example, the immune paths and mortality rates among different TB strands remain uncertain due to the strands' genetic differences. Furthermore, every person's immune system reacts differently to a disease, and one individual's immune response may be better than another's in preventing them from foreign invaders. So understanding what immune paths and outcome each TB strand produces will help researchers provide better protection for those with weaker immune systems or those who contract the more virulent strands of TB. Another thing is that TB in children is harder to detect since they usually have pulsibacillary disease, meaning their TB is caused by a smaller number of bacteria, and this makes it harder to obtain specimens for microbiological diagnosis, which makes children who has latent TB appear negative on tests. Another research area is to develop more effective vaccines to better fight the disease, which helps to decrease the prevalence of drug-resistant TB. Also, the development of more TB vaccines would be a long-term investment in preventing the spread of the disease. In conclusion, treatment for TB are available at a cost of approximately $2,000 per patient for a standard 6-month course of medication. Furthermore, treatment for drug-resistant TB can cost up to 25 times more and take 3 times longer. Moving on, currently there is only one TB vaccine that is licensed globally, and it is called Bacillus calmette-guerin, or BCG. And although the vaccine has shown to be effective in preventing severe forms of TB disease in infants, it provides minimal effectiveness in children and adolescents. Our current limited understanding of the epidemiology of drug-resistant TB and the interventions needed to limit its spread reinforces the need for increased financial funding for developing better treatments, diagnosis, and vaccines to achieve the World Health Organization or WHO's goal of ending the global TB epidemic by the year 2035. These are the reasons why my group believes drug-resistant TB deserves the $100 million in funding. This concludes our presentation. Thank you.